Okay. Good morning, everyone. On behalf of Screen and Jay and the Rutgers Cancer Institute, hello and welcome to Community Cares and Project Echo. Thank you for joining today's session, and we hope that the information shared today will help you serve your community better. And just a few announcements before we begin. So the information contained in this presentation is not a substitute for medical consultation. A physician should always be consulted for any health problems or medical conditions. And our agenda today will be, as always, the series overview, introductions, the presentation, the case study, and then any Q&A. So the Rutgers Cancer Institute became a Project Echo hub in 2021. Project Echo is a movement to demonopolize knowledge and amplify local capacity to provide best practice care for underserved people all over the world. The Echo model is committed to addressing the needs of the most vulnerable populations by equipping communities with the right knowledge at the right place at the right time. And this is done by using technology to leverage scarce resources, sharing best practices to reduce disparities, applying case-based learning to master complexity, and evaluating and monitoring outcomes. So for more information, please visit Project Echo at the echo.unm.edu website. So I'm very excited today. We have Dr. Danielle Velez-Leitner, who is the Director of Men's Health and an Assistant Professor within the Division of Urology at Rutgers Robert Wood Johnson Medical School here in New Brunswick, New Jersey. She's a New Jersey native. Having grown up in Middlesex County, she earned a Bachelor of Science in Material Science and Engineering from the Johns Hopkins University and then graduated from Rutgers Robert Wood Johnson Medical School. She completed her urology residency at Brown University and then a fellowship in male infertility and sexual dysfunction at the University of Illinois at Chicago. Sexual health and infertility conversations can sometimes feel embarrassing, and Dr. Velez-Leitner and her team really strive to make patients and their partners feel comfortable from the get-go. She believes in listening closely to patients' concerns to craft a goal-oriented and individualized treatment plan. And her mission is to help patients build their families and recover and strengthen their relationships. So I will now pass it over to Dr. Velez-Leitner. Thank you so much.
Thank you. It's so nice to be here today. Thank you guys for inviting me. My role really today is to talk a lot about sexual and reproductive health in men with cancer. This is, I'm lucky in that one day a week I get to spend it at the Rutgers Cancer Institute, and that's really, what my clinic is driving towards, is trying to help patients get through their cancer diagnosis and plan for a life beyond their cancer diagnosis and treatment. I think if we could go to the next slide. Oh, should we do the pretest?
Yep. We have just about another minute or two to have people answer, and then what we'll do is we'll review the post at the end of the presentation after the post test.
Well, thank you.
You're welcome. Thank you. This is where there's always that joke about we should have the Jeopardy music because it always takes about a minute to get the pretest done. So if everyone can please, if you're able to do the pretest, if you can please answer the 3 questions, that would be great. Okay, I'm going to go ahead and end the poll, and then we can move on to the rest of the presentation.
Thanks. Okay, so I think frame of reference is always really important to getting started with talks. And the bad news is that we have seen a rising incidence in all cancer diagnoses in patients younger than 65, with 1% of those diagnoses happening in our adolescent population. But the good news is that cancer survival rates in the United States are increasing. And now, because of that, we're seeing this increased recognition that cancer and its treatments can have a substantial impact upon quality of life before, during, and after therapy. And that's especially important when you consider how many young people are surviving their cancer diagnoses and treatments. Long-term survival following that diagnosis of cancer, because it's improving in developed nations, really, I think, has led to this idea of survivorship clinics, which is what we benefit from here at the Rutgers Cancer Institute, because we know that living longer. Can we go to the next slide? Sorry. We know that living longer doesn't necessarily equate to living well. So we like to give our patients that opportunity to talk about what their concerns are as they're going through their treatments and what they can hopefully, regain as they get back to their normal lives. Next slide. That said, when I go in to see that patient when they've just received their cancer diagnosis, I often get this like rose closed type of image from their faces. Like most of the time, patients are really overwhelmed and they're really focused on, how could this have happened? What am I going to do? Am I going to survive this? And they're not necessarily thinking about what life might look like in 5, 10, 15, 40 years. So that certainly presents its own challenges. I think especially when we talk about reproductive health, because a lot of our cancer treatments, as you'll see in the next coming slides, can really damage our ability to have biological children and reproduce. On that next slide, you'll see this graphical representation of themes pulled out from focus group interviews with pediatric cancer survivors and their parents. And the bigger themes are the ones that are represented by the bigger boxes. And this is really the slide for the reason why I'm so pushy with my patients and their families, because a lot of times we have a very slim window of opportunity for fertility preservation. And we have a lot of data from survivors and their families that demonstrate regret. You can see that right in that top line, that big box of regret, when they're on the other side of their cancer diagnosis and that window for biological children has really closed. I think a lot of times patients and their parents talk about wanting just to get back to normal as quickly as possible. And they don't necessarily want to take that side step to address the fertility preservation piece. Sometimes it's that the patient was just too young to care or too young to acknowledge it. And then, the other thing that we see a lot was, I think that having that fertility discussion as a centerpiece of hope. So I like to try to bring that into my conversations with patients, is that, we're hopeful that all these treatments we've been talking to you about are going to treat that cancer, so that in 15 years or, whatever, you have that opportunity to think about your next step of family building. Fertility is an essential component of survivorship, and many times our patients are too sidetracked by, the other big pieces, that they don't know how to ask for that preservation piece. And by the time they get around to it, it can sometimes be too late. On that next slide, we're going to dive really deep into AP biology. But the reason why that window of opportunity is so tight is because sperm are some of the most rapidly produced cells within the body. They really come from these germ cells, which if you look at that cross section in the bottom left hand of the screen, you'll see this tube and that cross section, and you'll see these dark purple dots all along that outer perimeter. And those are actually the sperm germ cells. As they go through spermatogenesis, they're basically replicating and multiplying. So you always have an A cell, which just repeats itself over and over again, replenishing that population. And then you have a B cell. And that B cell is really what grows as it gets closer and closer to the inner lumen of that tube. That's what's really growing into the sperm. Mature sperm travel through the ready testis, which is the middle part of that cross section of the testicle. And then they store in the epididymis, which is sort of that like mohawk looking organ on the back half. And that's where they really mature and they learn how to swim. And then with every ejaculation, sperm get forced through the vas deferens and out into the urethra as part of the ejaculatory fluid. On the next slide, you'll see how many pieces of a cancer diagnosis and treatment can really impact sperm production. Those germ cells, those dark purple cells we talked about, are crucial for future fertility. And unfortunately, they're incredibly sensitive to chemotherapy and radiation. And if they're irreparably damaged by chemoradiation, patients won't have that ability to make sperm in the future. We know that hormonally active tumors, steroids, chronic opioids, they can all disrupt the testosterone pathway for patients. And testosterone is really needed for sexual health and sperm production. So that's another problem, when we get that cancer diagnosis. Other problems can come from surgery. Surgeries like retroperitoneal lymph node dissections, pelvic surgeries, removing a testicle, they can all result in issues with ejaculation or erectile function or sperm production again. And finally, the systemic inflammation, the fevers, the cytotoxic autoimmune responses that we get from cancer can also further impair hormones and sperm production. So all of these things are reasons why patients land in my office, either as they're going through their treatments or well beyond as they're recovering. Um, on that next slide, I think this is really the meat of the talk, which is that there's really no low risk chemotherapy. And if you remember nothing, this is really the slide that I want you to take home, because there are so many different types of chemotherapy agents. Oftentimes they are given in combination and in layers, and patients get a lot of different doses and et cetera, et cetera. And we don't have all the data or studies that look at, well, if I give you this chemotherapy agent in combination with BCD, what is that going to do to the sperm production? Will you ever recover that sperm production? We just have no idea. Um, if we really had to stratify, there are certainly lower risk chemotherapy agents. If I have someone that's been given vincristine or methotrexate or captopril, usually what I'll see is that 33% don't make sperm, but that over time, as they get farther and farther from that treatment, they start to get some return of sperm production. Higher risk agents, certainly the platinum-based doxorubicin, BEP, which is common that we use in testicular cancer. About 40% of those patients are going to be azoospermic, meaning that they do not make any sperm. And again, we hope that as patients get farther and farther from their treatments, that they're able to recover that sperm production. But what we oftentimes don't know is what their baseline sperm production is. 1 in 6 men are going to have some component of infertility. And without a baseline semen analysis, we have no idea who's normal at baseline. So we don't know what that new baseline is going to be as they get farther and farther from their treatments. Certainly the highest risk chemotherapy agents, you're looking at cyclophosphamide, busulfan, ifosfamide, the CHOP protocol. 80% of those patients are going to be azoospermic. In other words, no sperm in their ejaculate after their treatments, and that's likely going to be permanent. We use the term germ cell failure, meaning all those little dark purple circles are ablated after those treatments. To put that into context, when we look at like lab-based studies and we're trying to recreate a model for infertility, we load up those animals with cyclophosphamide and busulfan. Those are the most common chemotherapy agents given. So my biggest take-home point from this slide is really that we don't know who is going to be at the highest risk of infertility after their treatments. So we recommend that everybody get that same insurance policy, which is bank sperm before you get any treatment. So you just have something to fall back on. On the next slide, you'll see that radiation also impacts spermatogenesis. So even with shielding, we do have some internal scatter that can still result in testicle dysfunction. On average, patients who get over 3 grays are expected to have permanent azoospermia. And even though the testosterone cells are more resilient, with high enough doses of radiation, we do see patients end up with low testosterone in a permanent way. Up to 20 to 30 grays. And certainly fractionated protocols can have similar or even worse protocols. And oftentimes patients are getting that radiation in combination with their chemotherapy. So that's really where we get antsy and try to slip in that sperm banking consult and recommendation prior to. On the next slide, you'll see that it's not just the distant future we're worried about, but it's also the immediate. So the ASRM, which is our main governing body within medicine, it's the American Society for Reproductive Medicine, as well as ASCO, we recommend that conception is not attempted with freshly ejaculated or extracted sperm within 1 year of their last chemotherapy or radiation dose. So it's not just that we're not making sperm, it's that if we are, it's likely to be abnormal sperm. And that possible DNA damage that we're seeing because of the chemoradiation can result in a higher risk of congenital abnormalities in offspring. On the next slide, you'll see the study where that really comes from. This was a population-based study done in Sweden, where we looked at children who were conceived naturally And they compared that to fathers who had been exposed to chemoradiation versus fathers who had never been exposed to chemoradiation. And what they found was that there was a 1.27 increased risk, relative risk of having a child with a congenital abnormality if that child was conceived within 2 years of the chemoradiation exposure. The old guidelines were 2 years. We've backed that off to about one, but I still like to recommend 1 to 2 years of backup contraceptive for patients who are currently undergoing their cancer treatments. But that also means that once patients get that chemoradiation, even if they're still making sperm and they're actively undergoing their treatments, we're not sure when that DNA damage happens to the sperm. So again, that safest time frame to really freeze and protect fertility for the future is before they're exposed to anything at all. On the next slide, you'll see the second ASCO recommendation, which is that male cancer patients should be counseled regarding contributing factors for infertility surrounding their cancer diagnosis as early as possible in the treatment process. Um, Again, I don't think I have to harp on why I keep going after this, because I think that that window between patients being diagnosed and then treated is so narrow. But in real life data, you can see on the next slide, again, looking back at those focus groups and interviews, you'll see that from the patient's perspective, about 50% of men, when they look back, will say, yeah, I remember someone telling me something about fertility and sperm banking but only 50, so 1 in 2 will remember that. And then if you take that next step of like, well, who actually went through it? Only 24% of men actually went and banked sperm. So there's some kind of disconnect happening between what our clinicians are advising and what their patients are hearing. And then my guess is probably some timing considerations where the patient said, look, like this isn't feasible. We just need to get to the treatment. And then they lose that opportunity. Um, Without banking, if you look at that next slide, ultimately, what we care about is live birth rate, right? Nobody cares about how many vials of sperm you have in the bank or pregnancy. What we want to know is like, well, how many babies are being born? And ultimately, what we see in that red line on both sides is that the survivors of cancer, when you compare them to their siblings, are less likely to have pregnancies and less likely to have children. Um, that was also associated with their type of cancer treatment. So the patients who received like high doses of cyclophosphamide or high doses of cisplatin were significantly associated with a decreased likelihood of conception in the male survivors, suggesting that because they got these high treatments, they didn't make sperm, so therefore they weren't able to have that biological child down the line. On the next slide, really this is where I like to try to slot in at the Rutgers Cancer Institute. So again, taking into account that the discussion of fertility should happen at the earliest possible opportunity prior to initiation of treatment. I try to slot in my consult in that planning phase. So as patients are undergoing their labs or imaging, maybe they're going for a biopsy or a port placement, we're hopefully getting that fertility preservation consult in. It's usually pretty quick. It's 15 to 20 minutes. I can do it over a telemedicine appointment if I really have to. I've done them you know, I've done them while patients are waiting to get in line to go to have blood work or imaging, just to get them those pieces of information that we've already talked about and give them options for how they can set that up. The next slide is really looking at like my algorithm in my brain. So thinking about, okay, well, how old is this patient? If they're under the age of 15, you'll see in subsequent slides, like they might not make sperm. So the idea of asking them to go through all of this might not be the most useful thing, especially if we're short on time. But if the patient is over the age of 15, we're 80% sure that they're probably going to make some sperm within that testicle. The next question is, can they ejaculate? Right. So we have some patients who might have already gone through some kind of massive pelvic surgery or retroperitoneal lymph node dissection, and they might not have that ability anymore because of all of those surgeries. So if they don't, we have other options. We can give them medications to try to force that forward ejaculate. We can check to see, we have some diagnostic testing like post-ejaculatory urinalyses where they literally orgasm or masturbate orgasm and then urinate. And we collect that urine and try to see, is there any sperm in there? Because if there is, we can probably spin it down, wash it, and freeze it for them. We can use vibratory stimulation that helps to promote antegrade ejaculation. And if none of these things are options, we can even do bedside procedures called TESSEs, which are basically testicular sperm extractions. It's a tiny testicle biopsy. They will not miss that tissue. And it's actually very well tolerated in the office or at the bedside, or I can even open up an operating room and take care of it there. But it's a 10 to 20-minute procedure, and the incision is about 1 to 2 centimeters big in the scrotum. But if the patient can ejaculate, certainly the easiest thing is to have them try to produce a specimen and then freeze it. This is typically done at an andrology lab, which most centers will have at like fertility clinics, like reproductive endocrinology clinics. That technician will spin down the specimen, they'll look under a microscope, and if there's sperm there, they should freeze it into several vials. If there isn't sperm there, we like to get a secondary analysis to confirm maybe that patient just had a bad day. But if on 2 specimens, there's no sperm in the ejaculate, at that point, we recommend going back to the operating room and doing a more exploratory operation called a microsurgical testicular sperm extraction or a microtessie. This has to be done in the OR because you definitely want general anesthesia for it. And it usually takes about 2 to 3 hours with a surgical microscope, basically going through the different leaflets of the testicle and trying to find tiny pockets of sperm so that we can biopsy the tube and then send it back to the lab for processing and freezing. Ideal number of vials, like what does that really mean? You go on that next slide, you can see that once we thaw the vial, it can't be refrozen. So if that person gives up, let's say 2 milliliters of fluid, most labs will try to aliquot that out into 5 or 6 vials. So that way in the future, when they're ready for their assisted reproductive technologies, we can thaw as few vials as possible to support that ART. Um, Two main types of ART. On the left-hand side, you can see intrauterine insemination, or abbreviated as IUI. Colloquially, patients will say, this is the turkey baster method of getting pregnant. It's nice because on the female partner, there's not as much burden. So maybe women take some medication to support that cycle, but they certainly don't have to do a ton of injections or egg retrievals. It's basically sitting in stirrups and putting a really tiny flexible straw into the uterus and then inserting the thawed sperm in there. Ideally, that vial should have 10 to 15 million sperm to really get like the highest likelihood of success with an IUI cycle. Versus IVF, where it is more burden on that female partner, but you see a lot more embryo count. So it's a little bit more efficient. We only need as many sperm as there are eggs in that retrieval. So if someone already has a very severe oligospermia, they're not making a ton of sperm, this is going to be the option that I recommend. Because even though our reproductive endocrinologists are excellent, they're probably not stimulating more than 10 to 20 eggs out of that female partner. So you really just need as many sperm as eggs are retrieved. Other timing considerations that I think about, patients really should have an appointment with their andrology lab to make sure that there's a lab tech available to immediately process that specimen. We don't want it just sitting around allowing sperm to die. Most of the time, these are early morning appointments. Specimens should be processed within 1 hour of ejaculate, again, to minimize sperm loss. If there are very low sperm counts, patients may need more attempts and therefore more time before they start treatment. So ideally, we're waiting a day in between, or 2 days every other day, in between ejaculations and attempts. But if I'm really pressed for time, I'll tell patients, look, who cares? Just do it every day. We'll freeze what we get and then move on to your cancer treatment. But bear in mind that, if that patient does 2 attempts and there's nothing in there, we need a day or so to coordinate that microtessie. So I think that's another consideration I always have in the back of my brain. And the other thing is that ideally we're not giving chemo or radiation within 2 weeks of that surgery. So again, it might cause a little bit of a delay. So the earlier that we can get that consult and those initial results in, the better the patient care is going to be. I like to recommend 8 to 10 vials of ejaculated sperm that might require 2 to 5 attempts, spaced 1 to 2 days apart. So again, earlier is better. And then I like to review those results with patients. Again, even if it's via a telemedicine appointment, totally fine with me. But I just like to give patients, and if they have a partner, an idea of what fertility might look like for them in the future, so it's not a surprise down the line. On the next slide, you can see another mail order option. So I think I didn't get to see where everybody was coming from, but certainly not everybody has easy access to a fertility clinic. So in this case, we'd like to use the fellow kits. These are mail order kits. You go online, you purchase it, it's mailed directly to their house. I've had patients do this from their hospital beds, and if they can't get a specimen out to the local lab, if they're admitted to the hospital. And these are basically kits where the price accommodates the overnight shipment. It comes with a proprietary fluid that keeps sperm alive for 2 days. And it goes back to the UCSF Andrology Lab, which is world renowned and excellent. There are certainly special considerations or barriers for preservation in our pediatric and young adult populations. Things that I think about a lot are that patients may not, I think this is probably an active slide. I'm sorry, if you could just click through 2 or 3 more times. Patients may not be sexually active yet. It's certainly a weird conversation to have with someone who's 13, 14, 15 years old. They might not have thought about parenthood. This might be completely out of left field. I get a lot of overwhelmed families in these situations. So it's more than a 15-minute conversation, just to let them think about it and process. And it might be, okay, let me come back later today. So when your questions are ready and you can ask them. There are certainly long-term costs. So if they're needing to pay that annual storage fee, if the patient's only 15, they're not thinking about kids till they're in their 30s, that's 20 years, 15 to 20 years of storage costs. And then it's the question of like, can the patient ejaculate? Are they even making sperm? We've got one study that really looked at sperm production in our young adult population. And what you can see is that around age 14, 15 is where you start to see the rate of azoospermia or lack of sperm in the ejaculate really drop down to about baseline population of adults. So if patients are under the age of 15, I'm a little bit cagey. If they're willing to try, I'm game. But under the age of like 14, I'm usually a little bit more leery and starting to think more about clinical trials. If you go to that next slide, that this is just going quickly. I feel like I'm probably short on time. But going through one example of a trial, this is really run out of the University of Pittsburgh. It is approved through an IRB at Rutgers Cancer Institute. It basically involves taking a small biopsy out of the testicle. It's probably about the size of my pen eraser cap. And then looking through that specimen and finding the germ cells, so not mature sperm, but just the germ cells, and freezing those. Under the IRB, 25% of the tissue is de-identified and dedicated to research so that we can figure out how to stimulate those germ cells. And 75% of the tissue is frozen for patients' future use. If you go to the next slide, it'll show how how this research is coming along. It really started in the lab with 5 pre-pubertal rhesus macaque monkeys. These are, well before the age of puberty, where we would expect sperm production to start. These small testicle biopsies were taken out, and you can see that in the A box. And then the monkeys were exposed to busulfan, again, so one of like the highest risk chemotherapy agents. The original tissue was then put back into the monkey and then stimulated with different hormones. And then 9 months later, when they looked back at those implants, they found mature sperm, which you can see in that last right side box, D box. If you go to the next slide, you'll see that they were able to take that sperm and use IVF ICSI with a female monkey. And several months later, Grady was born in 2018. And to our knowledge at this point, they certainly are monitoring her to make sure that she's a normal monkey, which is meeting all her milestones, and she's doing quite well. So this is lab proven, but when we think about taking that next step to humans, we're not quite there. So when I have patients enroll in these trials, it's usually somebody who's already received chemotherapy or radiation, so they're not willing to take that risk of the congenital abnormality for their children in future children, because that exposure was within the last year. And we're worried that if they continue to get more chemoradiation, they're going to lose that opportunity to make any sperm permanently. Or it's somebody who's just not making sperm yet. I've had kids as young as 7 enroll in these trials because their parents just want to hold on to that possibility for them in the future. On the next slide, you'll see it's the next step that they're really taking with the research, and it's that there was one child who was prepubertal when he was originally diagnosed with osteosarcoma of the femur. He was in the early stages of his cancer treatment. They enrolled him in this trial, and now he's a young adult. He's in his early 20s. Semen analyses have shown that he is azoospermic. All that treatment means that he is not making any sperm at this point. So the researchers took his original tissue, thawed it, resuspended it, and then with ultrasound guidance, injected it back into the center of the testicle. And we're basically just waiting to see how it matures and if it takes. I'll keep you guys, stay tuned for any results. But in interviews with this patient, he says that even if this experimental transplant doesn't work, he's hopeful it will at least guide future research. And he's grateful that his parents years ago made a call that gave him the option to make choices for him today. And that's something that I try to drive home with my patients is that, if we have the time, if you're willing to take on that extra risk, this may give your child options in the future versus closed doors. On that next slide, what about the patients who don't preserve prior to their cancer treatments? It doesn't mean that the door is completely closed, but we do have some options to try to stimulate their testicles. Always waiting that 1 to 2 years post chemoradiation. I like to get early AM hormones, testosterone, estradiol, a follicle stimulating hormone, and a luteinizing hormone to figure out what's going on at baseline. Physical exams are useful, and then a baseline semen analysis. If the patient has low testosterone, there's certainly a role for stimulation. We certainly do not use exogenous testosterone like gels and injections because those are basically male contraceptive. But we do piggyback off of some of the female fertility drugs like clomiphene citrate or anastrozole or HCG, Pregnal, et cetera, et cetera. And we're hoping that that's going to stimulate the testicle into hyperdrive to make more testosterone and as a byproduct, make more sperm. I think we can probably skip the next slide so we can get to everything. But the next one looks at.
Doctor, we have about 25 minutes left.
Oh, never mind then. Okay, so go
Okay.
back to the fertility preserving options. This is just sort of what I think about in terms of options for not just my cancer patients, but also like my non-cancer patients that come through my clinic that are thinking, we're having trouble getting pregnant, my T is low, what am I supposed to do with this? Selective estrogen receptor modulators like Clomid or N-clomiphene are incredibly useful by basically blocking off the estrogen receptors in the hypothalamus and pituitary gland. And that forces higher levels of FSH and LH, which talk to the testicle to force more sperm production and testosterone production. Patients that come through with higher estrogen at baseline, I try not to start them on Clomid because it'll likely drive that estrogen higher. But I really like aromatase inhibitors because they basically block off the conversion of testosterone to estrogen, and then you get a 2-for-1. You normalize the T to E ratio, and you increase the testosterone while also usually seeing sperm production improve. For patients who don't respond to this whatsoever, we can move on to HCG injections, which is a luteinizing hormone analog. And that really helps with testosterone production, but it is quite expensive, especially if the insurance program insurance won't pay for it. So it usually requires a lot of peer-to-peers and prior authorizations. We can usually get something covered, but if there's no coverage, it ends up the cost can sometimes be quite prohibitive. Patients will typically take medications like this for 4 to 6 months to really get those normal testosterone levels before we start to see that impact on the testicle. So for taking a step back, I think for the female side, women make a mature oocyte or a mature egg, hopefully every 28 to 32 days. Men take more like 3 to 4 months to make sperm. So it's just a longer ramp. So I like to tell my couples that, if you're thinking about getting pregnant, if you're having some difficulty, again, earlier is usually better because usually by the time my couples get to me, they want to be pregnant like yesterday. Looking at that next slide, what happens to the microtesty patients who are post-chemotherapy? So these are the patients where they might not have banked. Now they're completely azoospermic. They don't make any sperm. And we're looking surgically into that testicle to see if maybe we can just find tiny little pockets of sperm production under the microscope so we can harvest that sperm and use it for IVF. We do see some sperm retrieval, but it is certainly lower compared to patients who have not been exposed to chemoradiation. So typically I'll quote a 50 to 60% retrieval rate for my non-cancer patients. But you can see here in this retrospective study that post-chemo patients look at about a 37% retrieval rate. And even with sperm retrieval, we typically will see lower fertilization and clinical pregnancy rates compared to our non-cancer patients. And again, looking at the variation in chemotherapy agents, alkylating agents tend to see even lower sperm retrieval rates, only 21% versus 46% of patients who are not exposed to chemotherapy. Shifting focus a little bit from reproductive health, sexual health is also really important for survivorship. I showed that slide earlier on about how everything that goes into cancer can certainly impact sexual health. The chemotherapy, radiation, surgery, low testosterone, and just aging in general, we tend to see a decline in sexual health for a lot of patients. That can cause changes in erectile function, libido, or sex drive, fatigue, which can play a lot into body image. A lot of my patients will come through saying, hey, everything that you've given me has really improved my erectile function, but I have no idea where my penis went. It's a significant penile length loss. And that's something that's not completely preventable, but at least can be minimized with certain treatments and medications. Anorgasmia is a very common side effect of a lot of our cancer treatments, and ejaculatory dysfunction as well. And we know that sexuality and intimacy are significantly associated with health-related quality of life for all ages, even among the elderly. So, nothing makes me sadder than when patients come through and say, am I just too old to be worrying about this? And I say, no, you've made it to ages 60, 70, 80 plus, and you've worked on keeping yourself healthy. You've clawed your way out of your cancer diagnoses and treatments so that you can live your life. And now just tell me, how do you want to live that life? And we can try to get you to that point, using what we have available to us. But if it's a priority for the patient, it's a priority for me. We know that looking at prospective studies of thousands of cancer patients, many patients will suffer from substantial sexual health deterioration, even up to 5 years from their cancer diagnoses. The orange and the brown bars here represent moderate to severe sexual health deterioration. And this was present in all forms of cancer, whether it was thyroid, lung, prostate, melanomas. Men with cancer in all body sites and all ages reported suffering some negative sexual repercussions. But in that bottom slide where you're looking at the older men, you can see how much more prevalent it is. The much larger, less green, more orange and brown. And unsurprisingly, patients with the worst sexual health deterioration scores were also found to have higher rates of depression, anxiety, and fatigue. Unfortunately, 55% of these patients lacked any outlet to discuss their sexual health. And I find that really unfortunate because there's a lot of different things that we can do to address these concerns. If you go on the next slide, where do I slot this in for patients? I think that it's parallel to and not just following their treatments. At the Cancer Institute here in New Jersey, we try to make ourselves available, and not with nearly as much urgency as like our reproductive and our fertility preservations, but certainly if patients are concerned about what type of sexual health side effects they may see during treatment and after treatment, we're very happy to get you guys in so we can talk about it and prepare expectations and try to offer medications or techniques to offset some of those side effects. I like during those appointments to assess early baseline function, because I like to say, if the baseline isn't great, what we're about to do for you to treat your cancer is not going to make it better. And so at least this way we know where you started and we can provide realistic expectations and plans going forward. For my prostate patients, like my prostatectomy and prostate radiation patients, I like to set expectations that when we take that prostate out, it may take up to 2 years to really regain erectile function. And that doesn't necessarily mean you're not going to have sex for 2 years, but it might mean you need more support to get it done. I think that early appointment allows us to help protect anatomy, like with maintaining that penile length instead of losing it to fibrosis and contraction. And a lot of patients will say that it helps to create some hope. It helps to relieve anxiety. It gives them something to look forward to and shift the focus away from just being a cancer patient. What happens at these follow-up visits? We talk a lot about vacuum erectile devices. We talk a lot about erectile dysfunction medications, of which there are many. It's more than just Viagra, Cialis, and pills. We have gels that go inside the urethra. There are injections that go inside the penis. There are a host of different testosterone treatments that we can offer if the patient is amenable and that's a reasonable plan for them, and they're symptomatic from low testosterone levels. For my erectile dysfunction patients who fail everything else, we also have surgeries. I mean, we put in a lot of penile prostheses, which you can see in that bottom right-hand corner. These are basically very discrete devices that sit completely inside the pelvis. No one knows that they're there, but they help. They're really reliable. They allow patients to reliably access a firm penis for sexual activity without sacrificing any of the sensation or orgasm that go along with it. We probably do I think we're up to like 50 to 75 of these surgeries per year at Robert Wood Johnson, mostly in New Brunswick. We also do a lot of urinary continence surgeries. So, especially for my radical cystectomy with neobladder and my radical prostatectomy patients, or even my radiation patients, sometimes what we see is a lot of leakage, and patients come in saying, oh my God, I'm going through, like, I'm spending my life savings on diapers and pads, and I can't get through 9 holes of golf without having to change my clothing because I'm soaked. And in those situations, we have slings, and we even have sphincters that really help patients to just maintain that quality of life during and after cancer treatments. I think continence surgeries are probably the most highly satisfying operations I get to do as a urologist at Robert Wood Johnson. And then other sequela, sexual dysfunction that can happen from cancer, ejaculatory dysfunction, orgasmic dysfunction, pelvic pain syndromes. These are all things that can significantly impact quality of life. And we have options, whether it's pelvic floor physical therapy, sexual health counselors, partner support, different medications. These are all things that can be helpful for patients. And I think a lot of times make them feel like they have some control again over their life. Dedicated survivorship clinics have been shown to really improve patient quality of life. There was a 2015 article published in Cancer, you see on the next slide, uh, looking at men who were post-radical prostatectomy, and they were followed by a survivorship clinic. And these men, when you compared it to 235 men who had not been followed, the before group is highlighted in red, and then the after group in blue. And you can see even at 3 months post prostatectomy, the men in blue who were followed with the support of a survivorship clinic had much better average sexual functioning scores. And you can see how on the right-hand side, a greater proportion of these patients were actually able to recover 75% of their baseline function in the after group compared to the before group, even at 2 years post-op. And I really think that's because patients are keeping it in the forefront of their mind. They're taking medications, they're taking action, and as a result, they're able to enjoy their sexual health, as they enjoy their new lease on life, hopefully. In conclusion, we feel very strongly about sexual reproductive health here at the Rutgers Cancer Institute. If you're in New Jersey, I encourage you to reach out for appointments if you have a patient that just wants information or wants to talk about options and possibilities. I see patients in the clinical academic building, which is more of our benign side, and you can see that 7775 number. And then I'm usually at the Cancer Institute on Mondays. We just opened the Morris yesterday. It's beautiful. And that incoming number is the 2465. I'm also open to email. I usually live and die by my email. So if you have a question or just want to, pick my brain, I'm happy to, to answer anything that I can.
If anyone, I don't see any questions in the chat. If anyone has a question, please feel free to unmute and ask. I do have a question for you, Dr. Veles-Leitner. So, when you do have those discussions, are you finding that, are you getting partners maybe initiating more of those questions than the actual patients? I was just curious about that.
Yeah, I think it's pretty 50-50. A lot of, I'd say half the time, the patient will come without a partner because they're just embarrassed and they're not sure what to expect. And I usually will encourage them, especially if they're thinking about like injections or surgeries and things like that. And just say, look, like if you can, bring your partner next time, because partners tend to have 1,000 questions as well. And you're going to need support to get through this. And it shouldn't just be a one-way street. And I think that the other thing I like to emphasize to my patients is that there are a lot of ways to be intimate. So, you don't have to have an erection to be able to have that intimacy with your partner. What we want is you to be able to have a trusting relationship. But if there are parts of your sexual health that are missing, then it's usually better if the partners can also hear that it's normal, it can be expected from the cancer treatments. This is not their fault, because I hear that a lot too, and that we have ways to hopefully treat it. But it might just be a little bit of a road.
That makes sense. And then I noticed there was one slide where you talked about pregnancies, births, having children versus siblings. And I was curious, obviously some of that would be kind of like the consequence or the results of treatment. But then there was a part of me that was curious because we've talked a lot in past sessions about the mental health of cancer, fear of recurrence, those sorts of topics. And it made me wonder if there was any percentage of where maybe they held off on having kids because they were afraid they would, that fear of cancer recurrence, they might not be around for future children. So that kind of, I don't know if there's any kind of study or anything like that that maybe can attest to maybe that might be part of a reason why some people weren't having children.
Yeah, no, I would guess that there probably is some study that talks about it. I think the one that I reviewed in that slide, no, they didn't go into enough detail to ask about it. But anecdotally, it's certainly something that I hear from my patients of, it's usually my older patients, so their later 30s, 40s into their 50s, where they say, look, I don't have kids now. Would I have wanted them in the future? Maybe, but I'm afraid enough that I wouldn't be around for them that, this is not something that we're interested in. And I also have a lot of patients say, look, I'll thank you for the information, but children was always something that was sort of on the periphery and not really a focus. And I think that this new diagnosis has really pushed them off the map. So, I will not bank for in this situation. And that's fine. I always like to tell patients, look, um, I think my job is just to keep you as well informed as possible. And I want you to know all of the options because I'm not you. I don't know your life story. I don't know what your plans are, but I want you to be able to make informed decisions that are right for you. Um, and if that decision is you're going to proceed, like I need some time to be able to facilitate that for you.
And then we do have a question in the chat. Oh, out of curiosity, how did you get into this field?
Yeah, I got really lucky. So when I was a medical student, I knew I wanted to do something surgical, and then I happened to rotate in urology in my first elective, and I loved it. It was an easy choice to do urology for a residency. And then as I went through my 5 years, we do every field of urology, but I just got along the best with my infertility and sexual health mentors. I don't know. I really like that I get to hang out in the cancer center. I like that I still get some pediatric exposure. At the end of the day, I just really like talking to couples about their relationships and their families, and I find that to be the most satisfying thing. So I got lucky.
Oh, thank you so much. This was a very I mean, I love these sessions because I always learn so much and I learned a lot today. So I hope everyone else did too. And the way we're going to check that is we are going to launch our post test. So give me 1 second to pull up the poll. So if you can all please take a moment to answer. So if germ cells are irreparably damaged by chemoradiation, patients can't make sperm in the future. Um, ASCO recommends that male cancer patients should be counseled regarding contributing factors for infertility surrounding their diagnosis as early as possible. And then one study in France found that 55% of these patients lacked any outlet to discuss their sexual health. So let's give it just another minute or so. I like to get a 75% participants, and we're at 40% right now. So if the few of you can please answer the questions, that would be great. And I feel like the first question might be a little interesting. So, and let's see. Let's give it another couple seconds because I'm really curious because just trying to think. I'm not sure I know the answer for the first one. I felt confident that I did, but now I'm not so sure after hearing the talk. All right, so I'm going to go ahead and end the poll and share the results. So, what are our answers? Oh, you're on mute. There we go.
Yep. So if those germ cells are irreparably damaged by chemoradiation, patients are not going to make sperm in the future. We really need those cells to be able to divide and then
Exactly. So I got it right.
and then for the second one, Asker recommending that male cancer patients should be counseled regarding contributing factors for infertility surrounding their diagnosis as early as possible. True. And that last one, yeah, one study in France found that 55% of patients lacked any outlet to discuss their sexual health. Also true.
Fantastic. Thank you so much. So now we're going to go on to our last few slides. Sorry, my buttons are kind of acting a little crazy today. So, the Survivorship series is actually sponsored by the New Jersey Department of Health, and so we always like to provide some information. So in our state, we have NJCED, New Jersey Cancer Education and Early Detection, and it's a program run by the Department of Health in collaboration with local agencies and healthcare systems. The NJCED program provides education and outreach within the community about different types of cancer, and they provide free screenings to those that are unemployed, uninsured, underinsured, or face barriers to getting the cancer screening they need. So the SEED program currently provides screenings for breast, prostate, cervical, and colorectal cancers, and the program is offered in all 21 of our counties. This is where I do my plea. Please let us know how you did. This is how we can continue to bring these wonderful programs to you. So please let us know. The um, I will drop the link in the chat. And see how we're doing on time. And then also, we've recorded the session. The PowerPoint and the recording will be available on Mighty Networks. So please remember to, if you haven't done so yet, please remember to sign up to Mighty Networks, and I will put that link in there as well. And here is our seed link. So if anybody has services where they're working with people who are un or underinsured that need cancer screenings in New Jersey, please go there. And then finally, our next session will be on July 22nd at 10 a.m. Eastern Daylight Time, and it will be Lymphedema Explained. So I look forward to seeing everyone at our next session on July 22nd. I want to thank again Dr. Velez Leitner. Thank you so much. This was an excellent session. And if anyone has any questions, please reach out to us on Mighty Networks and we can get Dr. Velez Leitner to answer those questions. Thank you, everyone. You have a great day.